Hello? Okay. Okay, we're in the home stretch. Yes. What a long day, but great day. So we're talking about kind of a hodgepodge stuff. Family planning, women's health, and pediatric care. Hello? Okay. Oh, interesting. Okay, so we're talking about some family planning, women's health, and pediatric care, which is kind of a hodgepodge, I think. But we're gonna do it. We have a really good star-studded panel here. So I'll start with Tanzania, who actually is my patient. She's a business background. She's an MBA. She's one of 7 children. All 4 girls in the family have some sort of autoimmune disease. One of them I also see. So it's, yeah, I mean, like, what are the odds, right? I mean, like, you know, it's been crazy. You're president of Cultivate, which is a business resource group that promotes the professional development of African American associates and allies. And she's great. She's a great advocate. Dr. Carolyn Goldschmidt, she is at North Shore, I guess Endeavor North Shore, and a couple of other satellite clinics. I first came across her at Loyola. We were co-residents. And then she went to Cleveland Clinic for a Sylvia Lowry Fellowship for 2 years and returns to Chicago now. So she's great. We have Lauren, who we've met earlier. Lauren, do I have your stuff here? I do not. So, yes, I do. So Lauren, we know Lauren's story, right? She's the mom of Noah, which I'm glad is on the stage right now. So Noah's great. We've met him a couple of times. And I don't really have a bio for you other than that you're a tennis star. So we'll see what the future holds for Noah. So I don't have the cue cards that everybody else had, so I guess I'll just start. And we'll start with family planning. So yeah, one comment I will make, I think with all autoimmune diseases, especially neuroinflammation, I mean, it might seem dire at diagnosis, right? Especially a lot of these diseases affect young women, right? And a lot of times young women of childbearing age, right? And so I always tell patients, look, let's get through the acute stuff, let's get things stabilized, move on with our lives, right? I mean, you can't let it stop your life. And so we always want, I think I can speak for all the neurologists in the room, we want to be involved in a safe way of family planning and women's, I mean, everything, right? I mean, we can't just stop things. And the problem becomes sometimes is the FDA labeling for the drug sounds very scary for pregnancy because it's this downstream effect from the clinical trials. We can't enroll pregnant people in clinical trials, even if the drug's safe for pregnancy. We just can't. So therefore, the FDA, the legal language says not to be used in pregnancy, but the context is much more complicated, and there's a lot of fine tuning that we can do. Dr. Goldschmidt, any thoughts about that?
Yeah, I mean, I definitely always try to reassure my women of childbearing age patients, that if you want to have kids, we can totally do that. If you don't want to have kids, totally fine. Again, this shouldn't stop you. Like Dr. Conte, we want things to be, calm and stable for a period of time, but especially with the newer medications we have. And it's a really great time now because there are some actual trials and studies looking at a lot of our multiple sclerosis medications, but a lot of that can be extrapolated to these other diseases in both pregnancy and breastfeeding. And they are very reassuring in terms of the safety data for both pregnancy and breastfeeding, which is great. And as a relatively new mother, I understand the everything that goes into with pregnancy and breastfeeding and how important breastfeeding is for a lot of women. And so it's not anymore the time where we used to be like, oh, you just like, as soon as you deliver, like no breastfeeding, you have to get back on your med. It's definitely a shared decision-making process and weighing the risks and benefits and what is important to the mom and, how is their disease and everything like that. So it's a good time. Things are moving in the right direction for sure.
So Tanzania, you're a mom.
I am.
Yeah.
Yes.
So what's your perspective on all this as a mom?
So I actually was diagnosed in 2016, married in 2017. My husband probably thought he bought a lemon at that point, considering the fact, right? Joke, bad joke, but joke. But, right, we wanted to, I knew that I wanted to have a child, and we had to plan. We had to plan when I was going to stop, the birth control. And I had to have a serious conversation, or a number of conversations, like with my neurologist of the time, about the actual planning of it, right? Understanding and knowing, what that could do, or the medication could do to my unborn child, et cetera. So when we decided to move forward with trying to get pregnant, didn't take long, I really had to think about what you just mentioned, weighing the pros and the cons, right? Back then, there wasn't a lot of data available. The FDA-approved drugs were not available. I was on rituximab once every 6 months, and my neurologist of the time, again, in concert with her, we had to decide, do we stay on Rituxan during the pregnancy? How do we figure out if this is going to cause damage to the child? We have to weigh the pros and the cons. Again, as you heard me say earlier, I had a precursor, like my sister, unfortunately, right after she gave birth, she had the worst relapse ever, and she didn't have any medication at all at that time, right? So, and this was before she was diagnosed. She didn't know that she was diagnosed, or she didn't know her diagnosis at that time. But again, remembering her experience, literally right after she gave birth, right, she unfortunately had paralysis, optic neuritis. She couldn't hold her child for, almost a year, et cetera. So I made the decision that I wanted to continue treatment through pregnancy. We had a conversation alongside my neurologist, my OBGYN, and we had the treatment for after the first trimester completed. So I would just say that it's possible, but again, back then there wasn't a whole lot of data and research available, and I had a pretty decent pregnancy, to be quite honest, right? It was, and folks, I got pregnant in 2019. I gave birth in 2020. The pregnancy was actually pretty good until I caught COVID-19. So if you think about the fact that I was completely suppressed on Rituxan, right? I also contracted double pneumonia in my 8th month of pregnancy. And unfortunately, right, I gave birth to my child and unfortunately had to go into a coma for about 3.5 weeks or so because my body could not fight the COVID-19 at all, right? So the pregnancy in and of itself was not necessarily the problem, so to speak, right? I was able to do that, and I don't want to scare anyone, right? As long as you're in concert, again, with your doctors, it can be done. But for me, it was very difficult to then fight off. My decision to actually continue the medication and to continue to be suppressed, unfortunately, I couldn't fight off the COVID. I couldn't fight the pneumonia, and my lungs failed. And I had to go into a coma for a couple of weeks after that. And for goodness sakes, I think someone talked a little bit earlier about not being able to walk and, having to kind of relearn and have the support of family around, right? But you can do it, right? If you want to, have a child, you absolutely can. I just had a couple of things that were working against me. Number one, I waited till I was 37, 38 years old to get pregnant. And some doctors will call that a geriatric pregnancy. And somebody has got to do something about that terminology because I thought I was still pretty young. Come on. So I had a few things working against me, but again, I would just say that it's definitely possible. And as everyone mentioned earlier, you can overcome anything as long as you just keep pushing forward.
Yeah, anything's possible, right? We do want to be involved. The other context is a lot of the data behind pregnancy safety. So your story getting pregnant really quick is actually pretty typical most of the time, right? Usually the story with us is oh my gosh, I'm pregnant, and unexpected pregnancy, or we try to be fancy with timing things, and then it turns into this mumbo jumbo extended thing, right? That's the usual situation, and so because of the unpredictable pregnancies, we get a lot of registry data based on that, but there's actually some pretty provocative studies going on in the MS world looking at similar drugs as far as actual giving in pregnancy and studying how, the baby's blood dynamics go and safeties, including breastfeeding. So more to come, hopefully soon than just beyond registry. So I'm going to, for time's sake, transition to the pediatric stuff. So, the thing is most neuroimmunologists are adult trained, right? I mean, just large majority. There's very few pediatric neuroimmunologists that are specialized in neuroimmunology. Very few. I mean, couple, right, in the country. And thankfully, those people are doing a lot of the research in this regard. But a lot of these neuroinflammatory diseases present in pediatrics more so than MS does. So, where it becomes difficult because, peds are not just little adults, right? But we're adult trained. That's not even talking about the whole psychosocial aspect of having a chronic disease as a kid. So Noah, the tennis star, how did this shape, I guess, how old were you when you were diagnosed, presented? 12? Yeah, so you were starting high school at the time, or what would have that been?
That would have been my 7th and 8th.
7th and 8th grade.
Of school.
Yeah, so, obviously you were taken out, and then you had to return, and then you developed some complications. How was that for you?
It was definitely really challenging for me to get back into the academic side of school and catch back up because I missed almost half my 7th grade year and had to catch up right going into 8th grade and be at the same level as everybody else.
Yeah, and I think, everybody talks about we want normal childhood. So I think, most of my pediatric onset neuroinflammatory disease patients, I feel like they carry that trauma long term, right? The interrupted childhood. So I think it's good as much normalcy as possible, right? Like the quick return to normalcy is so important. So it's awesome that you were able to get supported in that regard. So then, Lauren, what was the way you were able to support all that? Sort of coming, very quickly into your lab.
So Noah was originally diagnosed when he was 12. He was on a field trip at school and he started having seizures. They were on a field trip. They were in a limo. They went to Culver's for lunch. He started acting abnormal and got back to school and he just threw up and passed out. I'm type 1 diabetic, so my immediate reaction is, oh my gosh, he's 11 years old. I was 11 years old, 12 years old. Oh my God, this is me. This is happening again. His blood sugar was slightly high. We went to the hospital and he started having more seizures. And then we got transferred to Children's in Milwaukee. Numerous spinal taps later, they diagnosed encephalitis. Immediately put him on IVIG infusion. He immediately started rounds of steroids. We were discharged and we were home for less than 24 hours and got a call from the pediatrician's office that his blood sugar was 500. And so we went back and got admitted again. So then he was diagnosed with type 1 diabetes. When Noah refers to we missed a good chunk of his 7th grade year, I was persistent about going to Mayo. I wanted to go to Minnesota. I wanted to talk to people. So we see Dr. Tillema in Minnesota. At Children's, we have a really good care team. Dr. Mondock is who we see for neurology, but now Freighter pairs with Children's, and so we see Amid Obadat at Freighter, so the two of them kind of pair together. I don't know, transitioning Noah now that he's 16, how that'll work when he turns 18. I know at infusion at Children's, there are adults that come to infusion at Children's, which is kind of weird to see, but I don't know if he'll get to stay there for infusions indefinitely or how that'll transition either. But it took us a while to get to where we are now, and now we're playing tennis and doing all the good things that we normally do, and he wants to start driving, and so we had a really rough journey kind of getting the diagnoses.
Yeah, and I think a lot of us talk about, so my big passion is health equity and these diseases, and I think you could pull in pediatrics to that as well, right? So not everybody has the resources for going to Mayo Clinic, right? I mean, it's right, you're next door state to you guys, right? And versus some patients have to get on a plane to go to those highly specialized pediatric neuroimmunology centers, and I think what gets tricky is again the delay in diagnosis, and as we know, the quick diagnosis does better long term because it prevents the damage, right? So having, sometimes having a dramatic presentation is a good thing if you look at it in a different way, rather than some of this insidious long term sort of, ramping up of stuff that then sometimes delays things, right?
Another challenge is treatment, because doing pediatric trials is hard. It's hard to recruit for. There's obviously not that many kids who have these diagnoses. Sometimes, they're trying to recruit people in different weight groups, and that can be challenging. So getting these medications approved is hard, which means getting them covered by insurance is very hard when they're not FDA approved for people under 18. And that happened in the MS world, where we really just got the first medication approved for pediatric onset MS. Before that, it was hard to get people treated with medication. And then again, we know that starting early is important. So, they're trying to do more clinical trials, but doing these clinical trials in the pediatric population is a challenge, and then that just poses more challenge for barriers to treatment, especially from an insurance perspective. Definitely.
I think from the biggest thing I have is going back through Noah's childhood and realizing that there were things that I was bringing to the doctor that were kind of getting misdiagnosed and pushed off. When he was 4 years old, he would complain about leg pain, and we'd get, it's just growing pains, or he would have night terrors, and he would wake up in the middle of the night crying, and we didn't know why. Headaches, it was middle school, it's hormones, it's puberty. When he was actually having seizures, he was excessively licking his upper lips raw. Nobody would confirm that with me. It's chapped lips, put, Aquaphor on. And when he was actually diagnosed, then I was finding out he was actually having seizures in his sleep. And so there were things that I would bring to the doctor and I would bring up, and I just kind of got pushed off as it was no big deal. Take Tylenol, go home, rest, just keep an eye on it, call us. Till it all exploded.
I think it's a pretty common story, actually. I ask my patient this all the time, especially the MS patients, where I'm like, when did you start having symptoms? They're like, a year or two. I'm like, okay. I mean, was there any time in your teenage years where all of a sudden you're stumbling or awkward or something randomly? And most people are like, there was this unexplained whatever, right? We hear that all the time, actually. If you just press a little further. And obviously that's with the, the gift of retrospection, right? What's that term? Where now we know, but, that happens pretty commonly. I think a lot of people in this room will probably resonate with that, actually.
I will say our pediatric patients are the most resilient, and you can see really, really amazing recovery in these patients. And I've seen, kids who were in a coma for months with NMDA receptor encephalitis, and then walk out of the hospital. It's because their brains are still plastic and very resilient, and very rehabable, and they are really some of the most kind of amazing cases that you see in that population.
Now, it also has women's health up there, which I always am like, women's health, what does that mean, right? So I think especially for NMO patients, right, where we see a lot, it's really a disease of minority people, intersectionality, right? We see really high rates, at least in this country, of Black women, right, which is intersectionality. Tanzania, if you're able to share some of your experiences with that as far as sort of your general health and how that, plays a role into things. It was a pretty broad question. But.
It was, but I'm gonna.
I didn't have the note cards.
It's okay. Well, I'm gonna put you on the spot for a second.
Okay, fine.
Okay. So he is my neurologist, right? And I will say, I have not met a doctor who advocates the way he does for his patients. Seriously. I had a great neurologist here in the city, but, still that advocacy piece just was not there. And I think truly pairing with your doctors, whether that's your OBGYN, right, if we're thinking about general health, and of course the practitioners, your general practitioners, as we talked about a little bit earlier, just keeping the open lines of communication and ensuring that they are fully aware, fully in tune of what you're taking, and keeping them up to date with any symptoms that you're having, et cetera. But the general health piece, if we're talking about that, I'm going to put him on the spot again. He literally, right, and we talked about it today, right, how important it is for us to get healthy, to be healthy. So, my neurologist was talking to me a little bit about, and full transparency, right? Like weight management and the importance, right? I won't say what he said, but it's so important. It's so important.
Sometimes.
Oh, yes, he is. But I love it. But no, I love it though. But right, like ensuring that you have like those doctors around you who can truly kind of point out where you just might be missing the ball. I'm an advocate for myself. I will absolutely read every single last thing that I need to read. I will ensure that I have the treatment that I actually have. I'll make sure that my doctors are listening to me, et cetera, right? But you can't have a bunch of yes people around you and just kind of like bypass the things that are not, easy or comfortable to talk about. He's just not that person, are you?
I'm not. I'm too honest. I get in trouble sometimes.
But it's true. You got to keep those individuals around you, and those neurologists, those doctors, et cetera, who will tell you the truth, who will just say, okay, like you're doing great in all of these areas. Now, let's tackle this other piece, right? Like, so when we're thinking about general health, I would just say, don't shy away from, those doctors and those specialists who will just kind of keep it real with you.
Yeah, and just in my defense, this wasn't our first visit where I started talking about like weight loss, by the way. But anyway, it's more of optimization thing. But I'm a firm believer, like the drugs are so damn good, right? I mean, especially for NMO these days. I mean, they're so effective, but they're not curative, right? You still have the previous damage. So what are we going to do about it? We got to help things. And we know the science shows comorbidities worsen disease and stuff. So, I just had a tizzy with a patient this week she was complaining of like, she's been short of breath and, all this stuff. I'm like, okay, well, have you been to your cardiologist and PCP? And she's like, no, I want to talk to you first. I'm like, okay, well, I am a neurologist. I do not deal with that kind of stuff, right? Like, you need to see your PCP. I actually have to remind some patients about this. I'm not your PCP, right? And I get it though, okay, because there's this trust, this mutual trust that has been developed. And I think especially in Northwest Indiana, this is actually a big problem where a patient gets diagnosed with MS, NMO, whatever, all of a sudden everything's related to it, right? The having stomach pains, all of a sudden, it must be your MS. Okay, well, the MS doesn't increase your liver enzymes, right? Like all of a sudden, whatever. Like all of a sudden everybody's blaming it on the MS. Talk to your neurologist, right? I mean, that happens, I think, especially bad in Northwest Indiana for whatever reason. And it's just, I'm not dissing it. I'm just saying it's just like the culture down there. And I think it's more common than people think, even at the big institutions here in Chicago, where all of a sudden a patient gets labeled with a chronic neurologic disease and everything's all of a sudden related to it, right? And so from an advocacy standpoint, you have to sort of obviously handle that delicately from the patient side, but just sort of just ask questions about, are we sure about this, right? That, are we sure this chest pain that's radiating to the arm and the jaw is not a heart attack? First, right? You know what I'm saying? It's not an MS hug if it's radiating to your jaw or, arm. And so, anyway, that's something that gets me going down to Indiana. Also, I get like clearance forms for like a tooth extraction. Like, okay, give me a break. Anyway, soapbox done. But right, Dr. Goldschmidt? I'm sure you get it up north.
We get a lot of that too.
Yeah.
I think for women's health specifically, there's been a lot more, which is great, like discourse at our meetings, and we're talking a lot more about hormones and how people's symptoms can change with menopause and all these hormonal shifts and pregnancy and postpartum, and circling back to the discussion about hormone replacement therapy and how that's, gone through different phases over the years. So I think having these more open conversations with people perimenopause, like how is that changing your symptoms? What can we do about that? Should we talk to your OB-GYN about hormone replacement therapy? How do your symptoms change with your period? Would birth control, having these open discussions. Are you having sexual symptoms? Like UroGYN, having a really good UroGYN who is familiar with these diseases, all that, having these like kind of uncomfortable conversations, but just like normalizing it and be like, we're going to talk about sexual dysfunction. We're going to talk about your hormones. We're going to talk about menopause, I think is very important, and people fortunately are becoming a lot more comfortable with it nowadays.
I would say from pediatric care, we really took advantage of complex care. My complex care person was kind of my back pocket person. Hey, I have this appointment, we have infusion, can we piggyback these 3 appointments? So a lot of Noah's infusions are once a month, IVIG is once a month. We go the first Friday of every month, and at that appointment, our diabetes doctor will come to clinic and do his lab work and his prep work and ask questions. He will see his therapist. He does see a really great, I don't know exactly what he is. He might be a psychologist, but the hospital kind of teamed with them. If I have a question about something or I feel like we need an optic neuro appointment, complex care makes that appointment. And they try to piggyback. So from pediatrics, we really took advantage of complex care for that. There's got a lot going on.
Yeah, I mean, any kind of resource like that, it gets so tricky sometimes with I don't really understand it. It's this whole weird side care thing with insurance companies where a patient's coming in for an infusion at my hospital, but they technically can't see me at the same day because then that's an outpatient and a hospital-based thing, and you can't bill both. It's very bizarre to me, but it's a thing. And so any kind of program, take advantage of it, right? We want to coordinate care. Do not be shy. And this is where we get the social workers involved pretty often, just sort of to ask the questions, right?
I think we see pediatrics, neuroimmunology, neurology, optic neurology, an ophthalmologist. We see so many levels of complex care that to coordinate all of it, it was really, really difficult in the beginning. So take advantage of that if you get that.
Okay, I'm getting some eyeballs. So any questions? Any questions, or we all want to go? Any final questions? Maybe 1 or 2, if anybody.
What an amazing job.
Okay, good.
Thank you.